Nice. All right. So I'm going to get started here. And let's see. So this is actually our 7th webinar. I haven't done one in a while, but we did a few starting last year and earlier this year. The videos of those are also online, but today we are talking about navigating value-based care with data analytics. There's a couple of kind of buzzword terms in there, so I'm going to start before we get into that. Just say a quick who are we and why you're even listening to me. So about us, Ionixx, we are just like a technology solutions company. We first started in fintech. If you're trading stocks on the New York Stock Exchange, you're probably using some APIs in the background that Ionixx created without knowing it. But as far as health tech, I do lead the health tech vertical here, and we've done some cool work in health tech as well. We could share something afterwards if anyone's interested. And about myself, according to the slide anyways, I'm a clinical product expert. So I've worked as a clinical product manager in the past for an EHR company. I've also worked at Accenture for a few years as a health IT physician consultant. And I do have experience in hospitals, policy payments. And yeah, I consult for both Fortune 500 companies and institutional investors who are looking to invest in US healthcare. So it's a little about me there. And so, all right, so I'm going to start just really at the beginning, just a quick slide on this before we get into data analytics. So I do want to say that I think this term is used pretty loosely, and I don't think the definition really reflects the reality of where we are in value-based care. So the definition I was able to find is really that it's supposed to be a healthcare delivery model aiming to shift the focus from the volume of service provided, which is our current fee-for-service, to the quality of care delivered. So when I hear that definition, it sounds like, patients are the ones who are getting some value, and the more value you give to patients, the more value that you will be getting as a healthcare provider. So that's a little bit of where I think the target was. But I think if we're going to compare it to our fee for service, I think it works best as a story. So all of us have been to the doctor. Imagine you go to the doctor because you're feeling unwell. Under the fee-for-service model, which is the model that we've all pretty much lived under, you pay for your visit to see the doctor. Your insurance may pay for part of it, but that is a charge. Every test the doctor orders, every procedure performed, and even the follow-up visit that's scheduled to discuss your results will be a separate charge. So if your doctor orders blood tests, an X-ray, and a follow-up appointment, to discuss those results, they're all billed separately. More likely you'll get a bill, all 3 bills from November 30th collated together a month later. You'll get a complex explanation of benefits that you don't understand, and you don't remember what happened a month ago, so you can't really fight it. So yeah, and it's also too late to haggle on the price of that $100 blood test. So as kind of non-transparent as the system is, it is straightforward in terms of you receive healthcare services and you pay for each service rendered. So it sounds like value-based care is supposed to improve that or fix that. So what we kind of did, though, is the actual implementation of value-based care occurs primarily through various incentive programs. So these are, or these include, but aren't limited to, kind of performance-based payment systems where providers are rewarded for meeting certain health benchmarks. These include PQRS, which is the Physician Quality Reporting System, HEDIS, which is the Healthcare Effectiveness Data and Information Set, MIPS, which is the Merit-Based Incentive Payments Program, MACRA, which is my favorite acronym because it's acronymception, because the C in MACRA stands for CHIP. So it's Medicare Access and CHIP Reauthorization, and CHIP, I think, is the Children's Health Insurance Plan. And then, you have CMS stars. So overall, I think, we see a lot of these different payment programs. Make sure we're working. A lot of these different payment programs, and that's kind of how it's been implemented for us here. We see, we have this kind of hybrid system where you still pay fee for service for seeing your doctor, but on top of that, there's now an additional layer that both providers and payers have to do or can do that will be able to get them some additional value from providing better care. So I think it is that this kind of financial and structural transition to a value-based care model is really challenging, and the transition includes navigating financial risk for the company, uncertainties, and I think it's been really difficult for a lot of these companies to balance it with existing fee-for-service models. So it requires a significant upfront investment, both in terms of technology, but also re-engineering processes and systems to support these initiatives. So I'm not going to go too deep into all of this. Let's move right into the actual role of data analytics. So I think the concept of data analytics generally refers to the process of examining data sets to draw conclusions about the information it contains. It's another kind of thing that may get misused a bit. I think, data science, for example, I think of more as creating new methods for data analysis, for data analytics, but I'd say data science is kind of the broader field that encompasses this entire spectrum. So I'm going to do a little overview of data analytics in value-based care. So obviously, data analytics is a wide field, and it works in a lot of things, but specifically for incentive-based programs like HEDIS and risk adjustment, this isn't going to be a direct jump to getting like the full value-based care and really focusing on patient outcomes improving. It's more of maximizing some of these metrics and some of these measures that exist in these different incentive-based programs. So just going to do a quick overview on this slide, and then the next slide we're going to do an example together. So hopefully we'll get some engagement there. I'm not sure how much we can do in this webinar, but yeah. So first, really, it's data collection from multiple sources. We need data from a lot of different sources, including EHRs, billing systems, patient surveys, other health information systems as well. And really, the diverse nature and formats of these data sources can make the collection process cumbersome and time-consuming. And a lot of healthcare organizations do shortcuts. They don't accomplish this step and end up doing a lot of manual work or pushing the work onto clinicians, relying on things like checkboxes and redundant data entry. I implore you not to look in the back end of some of these systems. It is a mess. So one of the things you have to do once you're able to actually collect the data from multiple sources is you need to standardize the data. So this is yet another hurdle, and you need to make it into a cohesive format. A lot of systems use varying terminologies, data structures, and formats, which adds additional complexity. And for instance, one system may categorize a disease or procedure in a certain way, and another one uses a different classification. Right? You can see like in the past we'd have like ICD-9 versus ICD-10. You could also have like some MSDRG classification, and then you're kind of trying to convert and overcome these inconsistencies. So the data needs to be mapped and transformed and all these things. Data accuracy and reliability. This is really important in these programs. So incorrect or incomplete data can lead to inaccurate reporting, which could affect the quality metrics and the associated incentive. So having to invest considerable effort into kind of verifying and validating the data before reporting it is really important. Also, not recommending it, but this is where people start to kind of fudge the data. It happens, but it's not supposed to happen, right? But ideally, we're not getting into that whole mess. And data analysis and reporting, again, it's not enough to just have the data. And I think when we get into our example on the next slide, it'll be clear. But it's kind of, you need to extract meaningful insight from this, right? It's not enough just to have all the data, have it clean, have it reliable. You need to actually do real life interventions in order to make a dent in these metrics. Reliance on external entities. I think this is actually a really important one. I think a lot of companies that are providing care may not have the in-house capability to handle this extensive data work. And even if they do, I think a lot of times it's just not worth kind of doing. I think having a data partner, this isn't a plug for Ionixx because we're not going to be your data partner, but having a partner that's kind of doing this, and you could focus on what's really important to your org. And I'll go into that again on the next slide. But they have data analytics firms or specialized health IT consultants to manage and manipulate the data. But I do think strong partnerships here are going to make a lot of difference for a lot of different companies. And that kind of goes into the time and resource constraints. The time and resource required to manage this data is pretty high, and a lot of upfront investment, as I mentioned earlier as well. So yeah, Dan, I think we hit capacity at 100. We have 103 in right now. I think we only have 100 in. I don't know if our team could look into it, but yeah, I think we're only allowed 100 in this webinar. Yeah, sorry about that though, Dan. There will be a VOD of this later, so hopefully they can see that. But continue here. So we're gonna do the example. So I'm just gonna share this example and leave it on the page here for a minute. You could read it. This is a real example. This is a measure that was added, I think, a couple of years ago, or maybe last year, and it's for the deprescribing of benzodiazepines in older adults, DBO. So there was a recommendation that benzodiazepines be avoided in older adults. So the guideline said to deprescribe benzodiazepines slowly and safely, so like a tapering, rather than stopping use immediately to minimize withdrawal symptoms and improve patient outcomes. So this measure assesses Medicare members 67 years of age and older who are dispensed benzos and wanted to achieve a 20% or more decrease in benzodiazepine dose. So this deprescribing measure presents an opportunity to kind of promote harm reduction by assessing the appropriate tapering of benzodiazepine dose. Okay, Brian's dropping. I don't think people need to drop. I think it's okay. We can, yeah. Okay, so basically I wanted to see, this is what you get from the measure, right? So there's like, how many of you guys would be able to design this measure in real life? So I also want to share that this is one measure of one VBC plan. So there are 90 measures in just this one plan. And there's several plans out there, many. So if you're an organization that wants to kind of get into this, it's kind of difficult to navigate from scratch. So you have to see, are they a Medicare member? So you'll have probably people in your population who aren't Medicare members. So you want to only include the Medicare members. Then you have to check where in your database it shows their age. Are they 67 plus? Then you have to also make sure that they've been prescribed benzos. So you need that demographic picture as well. So once you kind of have the definition of who you need to find, then you can start collecting data. So you need to collect data from pharmacy records. You need to collect data from EHRs. You need to collect data from Medicare claims data. And then once you have this data, you also need to check that data to make sure it includes dosage, right? Because this whole thing is about a dosage reduction. And then you also need to make sure it includes dates, because you need to make sure that it's going forward, that the data is trending downwards, right? You can't just have, they were taking 10, now they're taking, 15, they're taking 5. You have to know when that happened, kind of that trend timeline to show it's trending downwards. And then you also, again, still need to develop those demographics. So then finally, you need to also understand what the criteria is for deprescribing. I think for those of you who are reading this for the first time, it won't be clear what the numerator is and what the denominator is, right? Like just reading this paragraph, you'll be like, what constitutes a 20% reduction in benzodiazepine use? I don't know if anyone here will know. You might think, is it an average daily dose over a specified period? Like, do I reduce the dose by 20%? Is it, a comparison to the previous period? What are the time periods? Or is it that I reduce 20% of my population gets off benzos and the other 80% stay on? So it is, again, like you need to figure out what that criteria constitutes. And then after that, we're going to step 4, which is measure collection. So you need to develop an algorithm to calculate this percentage reduction in dosage over this time frame. So if you're able to figure out in step 3 what that criteria was, now you need to figure out how you're going to kind of calculate that. So you determine which patients meet the criteria for that successful 20% dose reduction, and then you track it over time, and then you have to show what's going on. So then fifth step, not finally, the fifth step, this is going to be now data analysis, insight generation more is where we're getting now. So this is kind of like you find trends, and in successful deprescribing. So I'm going to step back for 1 second and say on this measure collection, there's still a lot of work to be done about actually how you're going to get these physicians or these patients to promote deprescribing. So even if you're doing all this data stuff, there still needs to be a real life kind of conversation, or you need to add something into the patient portal or the provider portal to promote this. So that's kind of where I was going with the partnerships. If you're letting your data partner handle kind of some of these more difficult steps, kind of like defining the population, doing all these things, and because then I feel like what organizations can focus on is the actual deprescribing. Because even if you get all this data perfectly, you're able to find all the Medicare members, you know exactly what the criteria are and all these things. How are you going to make your physicians actually deprescribe benzos in this age group? You have to communicate that to them in some way, and each org will be somewhat different. But I did mention the patient portal, so maybe for patients who are 67 plus on Medicare, they'll get a notification of, hey, talk to your doctor about deprescribing benzodiazepines. Or the opposite for physicians. I mean, I think physicians get a lot of direction on these measures, and sometimes it's a little overwhelming, but it is to say, hey, like, talk to your 67 plus patients, whether they're Medicare or not, but still talk to your 67 plus patients who are on benzos and look into that. So the insight generation, though, is going to be kind of like, once you have those in place, you want to find the trends that are successful in deprescribing. You could say maybe it's per specialty, maybe it's per location. You're finding some trends that are working, some that aren't working. Maybe some prescriber practices are doing really well, and you could look into those and might find some regional variation. So it's really some kind of insight that you're getting from the data, and then you need to continue to, excuse me. And so even after you have some insight, you need to continue to improve things, right? So once all the data is flowing, once you have all the information, it really just isn't enough to just go with that. You need to have an insight. You need to say, how I'm going to make this better. And then once it's going, you need to continuously kind of monitor, validate, and make adjustments. And these adjustments should be based on the insights generated by your data. So when they tell you, maybe a certain specialty is doing really well, or maybe there's a department that's not doing well, you need to kind of turn those knobs and kind of fix some things. So just again, real quick, that's just one measure of one value-based care plan. So everyone here, I think, partnering with someone for the data part, so you can really handle kind of the turning the knobs part, makes sense to me. So your company can focus on the interventions, and it's kind of more win-win for everyone. Because I think a lot of these data teams, there's companies like Novolon, Optum, Sidious Tech, a few others, but all of these companies, they don't have any skin in the game to your value-based care payments. They don't have the insight, the clinical insight or insight into your population. So if you're able to find a trustworthy partner, which is the difficult part, I guess, who can handle kind of the data part, and all you have to focus on is the insights, I feel like that's kind of the more logical way to move. And so I already mentioned some companies, but I am going to go into one quick case study, and we're just going to kind of go through that last slide again, but just kind of with Neuron, which is a data analytics engine by a company called Calculated Health. So I did want to start with a disclosure. The reason I know about this company is because I worked with the founder at Accenture on a value-based care project. Geez, what was it? 8 years ago. So he was an expert. He really knew the industry inside and out, even back then. Years later, he kind of diagnosed what the solution was needed and set out to create it. So like I said on the last slide, there are competitors. There's a bunch of companies that do things, but this one is my pick of the litter, not just because I know the founder, but I'm going to go through why I really like this offering compared to others. So when you look at kind of the configuration, What I liked about this compared to others is really that it's adaptable. It can be deployed in a lot of different configurations and different environments. And my favorite aspect of it is the capability to operate without requiring PHI to be sent outside of the client's environment. So I think this is really unique. And it's one of the things I'm going to talk about in the future slide. Looking forward, I think this is kind of what everyone's going to start doing, because the founder once described it to me as we bring the analytics to you. So wherever your data is stored, Neuron just runs in that environment. You don't have to send it. There's no data transfer. There's nothing you have to really worry about. So it's kind of like a flat monthly fee. It's not charged every time that you run it. And yeah, it's pretty good for that. So I was saying that we bring the analytics to you should be their tagline, but I don't think he listened to me on that. So yeah, again, like we're going to go through kind of the impact. So when you remember the previous steps, we had defined the population. So remember that it was built into the measure. And what's not clear there is that there's also exclusion criteria. So you have to look at exclusion criteria, which is seizure disorder, REM sleep behavior disorder, benzodiazepine withdrawal diagnoses, ethanol withdrawal, which is alcohol, members in hospice care, members who died in that year, members who are in palliative care. So all of this in that define the population, which when I went through the example in the last slide, which is 67 plus, this, all those things are kind of built into Neuron. So you don't even have to define the population. That'll all be kind of done from the start. And then even the data collection and integration, you just need to map it once to where the data lies. And again, there's no sending or transferring of data. You just kind of connect it, and you're going to be getting that claims data. You're going to get those pharmacy records, that thing from EHR. As long as you have that data, it will just kind of pipe it in. And then developing the criteria for deprescribing. So again, it wasn't clear to me when I first read that what constituted a 20% reduction in usage. So do you know there's like something called the ITE, the index treatment episode? So that's kind of what it's focused on, and all those things again will be built into the criteria. So yeah, so now then once you actually have that, you have all this data, you can actually design your intervention that will make your population kind of reduce this by 20%. So this is what you get to focus on. So yeah, whether you use Neuron or you use someone else, kind of this is where when you're able to really focus on your group, what needs to be done for your population, which you understand the best, right? You're not going to be listening to your data partner for that. Because basically, if you're able to focus on the interventions, on improving care and how to intervene, then you're just going to have, I think, better outcomes, not having to kind of work on both parts of it yourself. And obviously having your own data team to work with your partner's data team, or, having some folks on your team is great. But again, the validation and testing, going to the next step. So I think all of these will be similar, but Neuron's NCQA certified, and they can't really mess it up. It's automated, which is a little bit different than competitors as well. So I have personally seen problems with implementations from other companies where they've literally been putting in the wrong data for 5 years. And 5 years later, they find out and they're like, oh, whoops, like, this claims data was actually not the correct one that we've been reporting. So issues like that happen, and it could happen to you as well. So I think it's really important, again, to do all that validation and testing up front. And then again, the data analysis and insight generation, you will get those trends in successful deprescribing, patient characteristics, prescriber practices, and this is all provided out of the box. So that's really great. You can see point in time also as well, how you're doing in these measures, and then you can look at trends off of that. So I think the source data and all the insights are just kind of sitting with you. You can look at the numerator and denominator yourself if you're more of a data guy. If you're the data guy, you can be like, okay, here's kind of where it is. You can do geolocation, trends by area provider. Whoever's working on your data locally, they can slice it any way they want it. And last thing, implementation and monitoring, kind of to continuously monitor and make adjustments. It is an open data model, and you can hook it in, like I said, to the provider portal and be like, hey, hey doctors, you deprescribe stuff, or put in the patient portal. Hey, are you on benzodiazepines? Talk to your doctor about lowering your dosage. And intervention for providers who aren't adjusting. You could say, hey, like I've noticed that these 5 providers are reducing, whereas this guy hasn't changed anything at all. Maybe I need to have a talk with him. Maybe you need to give it to your customer service rep, which may be less popular. Maybe you have a care manager who's going to handle this stuff. So yeah, so I would say just kind of choose your partners wisely. I'm not in the market personally, but I would say vet your options, get some demos, look into the differences, and especially try to run an example with them during your demo. So, I think this example was just for us here, but if you want to check out Neuron, the company is called Calculated Health. You could ask for Brian and say that Maanas sent you. So yeah, as far as future outlook, I think we are going to continue to be working on this with kind of some advanced data analytics. Everyone's talking about AI, so I think it's required by law to mention AI in every webinar just for marketing purposes. So I have been looking forward to AI saving us from paperwork. I think it's less of AI treating and diagnosing patients, but more of like, able to take care of some of the tasks that humans don't want to do and machines are more than happy to do. So yeah, I think AI algorithms are going to have some, streamlining effect on some of these tasks and even improving the decision making, right? We have all this insight generation. I think that's only going to get better. Local data processing, I mentioned this with Neuron already doing it, but I think it's so smart. I think all the competitors are going to start doing something similar in the near future. So it's really processing and analyzing the healthcare data kind of locally in that environment. So in a hospital or clinic, you don't need to rely on centralized systems. You can, even enhance data security with your local data processing, because that whole send and receive type stuff is ripe for issues there. So the next thing is really increase patient engagement. I don't think value-based care works at all without patient engagement. It's really a required, I think, kind of table stakes thing to be successful. I think we're going to see a surge in patient engagement, likely facilitated by technology. And I think that digital tools like, we see a lot of mobile health apps, wearable devices and things like that, starting to empower patients to take an active role in their health. Although most people don't, but I think there is a way that in the future we'll see increased patient engagement, which will lead to better health outcomes and hopefully better value for the companies as well. But the overall goal is, of course, patient health. So the last thing here on our future outlook slide will be collaboration across sectors. I think the success of value-based care, really hinges on collaboration across these various sectors. So partnerships between healthcare providers, technology companies, policymakers, insurance companies as well. So these collaborative efforts, I think, are required to kind of develop these shared standards and move us forward in these next things. So how we can help, I think we have a poll here. We have a poll here. We're going to ask just kind of like, are you like, I kind of want to understand, is our audience even looking for a tool to boost their data-driven decision-making? Or is it just kind of like, you're using one, you don't have one, it doesn't really matter. So I would like to hear a little bit about that, kind of where we're thinking. But yeah, I think overall, I would say my adage here is really, we do have value-based care expertise, and I always say diagnose before you prescribe. And that's not just for medication, it's really for anything. So if you're looking to kind of get this going in your organization, every organization is different. I'm not going to say like everyone should get Neuron and you're going to be doing great. It's really kind of like what your goals are, which programs you're signing up for, which ones you're really looking into, and kind of who your patient population is, right? If you're like a lot of people are focused on Medicare, there's some Medicaid ones as well. So it's kind of like, this is what I'm focused on. This is kind of what I want to do. This is our budget. And you have to kind of think, what can we accomplish? How can we get the most return? So, and I think it goes beyond implementation. It is more of like an ongoing partnership. You need, of course, to have all of your data there, but you need to also, I think the big focus for most of the companies here really needs to be those interventions. So what can give you the most time to, maximize your interventions and really improve all of these measures? Because remember, even the DBO example we went through was one of 90 in that. So you're going to be spread really thin if you're going to be trying to you know, create all the algorithms, do all of those things, make sure everything's working correctly, plus do all the interventions. So yeah, and so you really need like the data driving intervention. I think it's actually crucial. You're going to need to see you need that data and you need to make the intervention. So again, like as much as you can do for the interventions, I highly recommend that. And for those who attended today, I'm happy to do a 15-minute call. I think we're going to send out a Calendly link afterwards. But it's really to understand, like I said, everyone's unique and everyone has a different population, and only you understand your population. Don't pretend that any of the data partners are going to be like, oh yeah, we get it. I don't think they will. They're just going to be like trying to make a sale. So yeah, I think you really need to understand. I mean, I think I really would like to understand your needs and, say, hey, like, I would recommend this or that. Of course, like it's not going to be like a like, hire me to do this thing because I'm not doing any of this data stuff. But, other than Neuron, looking at other solutions, looking for how you can continue what you're doing. I see quite a few people are actively exploring options. I think 25%, 26%. So it is something that, if you're looking for options, you need to kind of understand both your internal landscape, which only you understand, and then understand kind of like the data landscape of who's out there, what's going on. And then you could kind of explore those options, find a fit, and move forward with, again, hopefully you're able to do more of the intervention piece and not keep worrying about the data if you're reporting the wrong thing for 5 years. So I think that's it for me right here. Sorry we went a little bit late due to technical difficulties. I wanted to do the presentation part in about 30 minutes, but we ended up 40. If y'all have any questions, yeah, if y'all have any questions, like feel free to type them into the chat. If there's anything that comes up later, these are all the ways to connect with me. I think I'm pretty good at LinkedIn and email. But yeah, thanks for joining today, guys. I'll just hang on to this for a bit.